Good evening, and I would like to welcome everybody to this phase of complex PCI arranged by Professor Ahmed Gindi, Aswan Heart Institute. And we really like to thank him for this, for his continued efforts for medical education and bringing all these experts, exchanging ideas on all the various different complex scenarios that we face in the cath lab all the time. Today, we have really exciting presentations with exciting panelists and presenters. I think our first presenter, before I can't forget to thank Medtronic for sponsoring and making this all happen. I would also like to welcome our guest, Professor Flavio Rebicchini from Verona, Italy. Welcome. Nice to have you. And Professor Omar Göketken, our old friend from Turkey. Welcome, Omar. Always good to see you.
Thank you, Iman. Thank you very much for
And I think we have a little bit of a change in the program, just a little rearrangement, and we're going to start with Professor Flavio Rebicchini's presentation first.
Okay. Okay, thank you very much. Just let me know if you hear me well.
We hear you well.
Yes, perfect. Of course, I'm very glad to contribute to these initiatives. The previous one last week was very interesting and very well attended. I hope this will be nice for you too. What I would do now is to start sharing my presentations, which always takes a little bit of time.
You're not the only one.
You know, we are not so young anymore, so all this new technology, it's a little bit demanding for us old people. And sometimes stupid things become difficult.
So while we set up this, we can have a reflect on the last session and have a few initial ideas. So we've spoken last time about controversy between CABG versus PCI for left main disease, essentially, and distal left main disease to be more specific. And one thing while there is some controversy on the best mode for revascularization in patients with left main disease, I think there's very little controversy or very little doubt when it comes to the absolute need to optimize and master your technique when it comes to left main interventions. So there's hardly anyone that would argue that if you decide to go for left main PCI, you really want to do it the right way. And there are a number of sort of important in the proper planning, but there are certain caveats when it comes to left main PCI that we hope through those two sessions we will help highlight so everyone can avoid. And this is exactly why it's sort of imperative that we start with what Flavio has to say on how to optimize outcomes, coming from someone with a huge experience in left main bifurcation disease and complex PCI on the whole. So this is, I think we can afford to give Flavio some time while he uploads the presentations, but I think that the sequence is important before diving into the cases per se. So perhaps we haven't really started, but this is to the audience. If someone has any burning questions related to last week's webinar, or the topic in general, we can sort of address those while we fix this technical glitch.
Well, I think the really left main PCI is an evolution. Our technique is in evolution. Our knowledge is in continuous evolution. We really can't forget that surgery is a mature procedure, whereas PCI is evolving.
Yes.
Our techniques change, and we're still learning. We have made we have made big steps forward with PCI. And I think really, if we want to be really frank, the aim, the current guidelines state that surgery is class A for all subsets of left main lesions, whether ostial, shaft, or distal bifurcation lesions. PCI is given 2A, and this is, of course, depends unless you have a high syntax score where it's a class 3. What I think Excel showed was that we have made big steps forward. And I think the aim of Excel, as we really know without it being actually declared, the aim and the hope in Excel was to perhaps be able to show non-inferiority of PCI compared to cabbage, so that it can move up in the scale, in the grading, up to a class 1 recommendation compared to equal with surgery. And I think that this is really where the controversy happened, why it happened regarding the results of the Excel trial. Just quickly, I'm just going to explain the basics of the Excel trial. They took patients with left main lesions, divided them into 2 groups. One group, surgical, and the other group, PCI. The PCI group, it was left to the operator to determine, obviously for the shaft or for the ostium, it will be 1 stent, but for the large group of patients who had distal bifurcation, left main lesions, it was left to the discretion of each operator to determine, based on their totality of the visualization of the lesion, whether they should go with a 1 stent technique or 2 stent technique, and whichever technique they chose. Ultimately, they were followed up for 3 years, where the results were equal with surgery, and then they followed them up at 5 years. At 5 years, something very unexpected happened in the results of Excel. We know in all our studies, we look for cardiac mortality. When we say the mortality, we're talking in the results of a study, we're talking about cardiac mortality. However, they put in the primary endpoint all-cause mortality. And for the first time in any study comparing stents with surgery, all-cause mortality was higher in the PCI arm compared to the surgical arm, which is a very unexpected and frankly unexplainable finding. And the problem is, it was a significant difference. It was 12% mortality, all-cause mortality in the PCI arm compared to 9.9. So this is, we'll say 10, it was 13. The difference was, absolute difference was 3% absolute increase in events, which is a very significant, it's a 30% increase. So it was 13 versus 10, and it's a finding that cannot be ignored. Now, the endpoint that we are used to in all the previous studies is always been cardiac mortality. And cardiac mortality was equal in the PCI arm compared to the surgical arm. And actually, this is what we look for and what we see in all the previous studies comparing PCI versus surgery. Now, there are other findings such as the acute infarct findings, which were higher, but the main issue in the Excel was really the all-cause mortality that was higher. And it's unexplained. I mean, how in the world are you going to put a piece of metal that is 98 microns thick and maximum 30 millimeters long? How is that going to have an impact on pancreatic cancer, colon cancer, or stroke, or car accident, or fatal car accidents? Whenever you have a finding in a trial, we always know that studies and statistics can easily be deceiving. You can find random findings. Example, this is not the first time. The first study that ever compared thrombolytic therapy for acute myocardial infarction was called the ISIS trial, International Study of Infarct Survival. And they compared two groups. One group got standard care for infarction, and the other group received thrombolytic therapy. In that study, everybody remembers that thrombolytic was good and wonderful and saved lives. But there's a very interesting find. People born under the sign, yes, the zodiac sign upstairs. If you're a Leo, you did better with thrombolytic. If you were Pisces, you did not do better. Obviously, this was not replicated in subsequent studies. When you gather data, you're going to wind up finding things that are unexpected, unexplainable, and most important of all, you cannot find a mechanism for the finding. And this is very important. If you find something in a study, you must be able to show a mechanism. Otherwise, it's an accident. It's an incidental finding. It is like the Capricorn doing wonderful with thrombolytic and the Libras not getting good survival from not having their arteries open with the thrombolytic agents. So I think really the other point is in statistics, statistically speaking, there is something called regression to the mean. What does regression to the mean imply? If you do a study comparing one drug to another, and you do it 5 times, and each time drug A is better than drug B. So the consensus, and everybody believes and everybody's convinced, and all the data says drug A has been proven in multiple trials to be better than drug A. If somebody does the same study for the 6th time, and suddenly drug B is better than drug A, don't believe it. Because if you do the same study for the 7th time, you will find the result showing that drug A has gone to prove itself better than drug B. This is called regression to the mean. So you can have accidental findings in a study. That's why, although you cannot ignore the increased all-death, all-cause mortality with PCI compared to surgery, however, we have to take it with a grain of salt and remember the 2 things I mentioned. The ISIS trial showing your zodiac sign will determine whether you have a good response or not to thrombolytic. And the second issue is regression to the mean. These are 2 issues.
Ayman, these are very well-spoken points, and I think we have a couple of minutes before we're up and running. Besides the sort of unexplainable finding of all-cause mortality rather than cardiovascular mortality, Do you find the change of definition of myocardial infarction midstream alarming? Do you think it has indeed changed the overall conclusion of the study? Or is this again our old fight about what constitutes an important infarct, how clinically relevant is an elevation of troponin or CKMB, and what are the cutoffs that do deserve clinical attention or have any clinical importance?
That's a very important point, and it was discussed extensively and was a point of extensive debate.
Yeah.
And okay, before I answer this, I have to say I am very sorry. I feel sorry for Greg Stone. Greg Stone is blamed either way. Before the results of the Excel trial came out, in the middle of the ischemia trial, now you remember the ischemia trial results came out and everybody talked about the results of the ischemia trial. Nobody mentioned Greg Stone. Nobody attacked Greg Stone. Nobody said anything about Greg Stone when the ischemia trial came out. Okay, now pause and rewind a couple of months backward. About 5-6 months before the results of the ischemia trial came out, Greg Stone was under intensive attack for being blamed for changing the criteria in the middle of the ischemia trial. Okay, what actually happens in large trials? It is quite common to change the definitions. It is acceptable, it is common. Why does it happen? Very simple. When you're going to follow patients for several years, you design a study and you determine what are your endpoints and what you will do. And then you start recruiting patients and following the inclusion-exclusion criteria. However, if you're, say, following patients for 5 years or what, over a long time, several years, medicine doesn't stop because you're doing a trial. There are other studies that come out that could very well make your initial inclusion criteria irrelevant. And this is why it is common to change criteria in the middle of a trial. What they did in Excel was due to the fact that they found that many people and many of the investigators were not measuring CK and troponin, because troponin costs money and who's going to pay for it, and hospitals don't pay for it. They had originally the universal definition, and then they changed it to the SKY definition. The SKY definition is the approved definition of SKY, and it was shown in a study by Ben Dorr from CRF, who showed previously that it was able to determine cutoff values that are not only that do not only show increase, but subsequent correlation with long-term outcome. So what is wrong with using criteria proven in a study to have a correlation with long-term outcome in the trial, because it was newer compared to what they chose earlier? This happens, and it happened in the ischemia trial. Everybody forgets it now because nobody is arguing the results of the ischemia trial based on what was done with the definitions.
Excellent, Dr. Ayman. Sorry, just cut you there, and we'll get to the other controversy regarding Excel, but perhaps after Flavio gets on with his presentation, I think we're up and ready.
Yes, we see it, and we're excited and looking forward.
From ICOM guys. Flavio, if you unmute yourself, that would be fantastic, and we're good to go.
Okay, thank you very much. I again apologize for the inconvenience. It's my task to give you some personal point of view about how to optimize the technique to avoid the complications. The key issues are the LV function, the presence of severe calcification, the association with aortic valve disease, which is quite common in elderly patients, and the anatomy of the left main, and of course, last but not least, the post-procedural care. Next, please. There are two issues. I will divide my talk in two parts. One is optimizing outcomes for the short term. So regarding the short term, I will address the issue of the need of hemodynamic support during the procedure, the preparation of the calcified lesions with rotational atherectomy or with lithotripsy, the use of intravascular imaging, and the bifurcation technique, whether to use single or multiple stentings. Next. As to the long term, of course, the long term of your procedure will depend on the patient more than on your technique. And this is the myocardial viability, whether you can recover LV function or maintain it normal, the renal function, which is a very important variable for long-term survival, the type of stents, because it seems from trials that stents are not all the same. Again, the use of IVUS might be a determinant of the good long-term prognosis of these patients, and the post-procedural organization and follow-up. So let's go to the first, which has to do whether you consider hemodynamic support, yes or not. If it is yet, yes, which kind? There is a low threshold for using inotropes or balloon counterpulsation. There is a very low utilization of more aggressive mechanical devices like Impella and ECMO. Next one. When do you use this kind of support? Next, please. You normally don't need to put a patient on assistance when his ejection fraction is higher than 40, which means his blood pressure is normal, when you don't have important mitral regurgitation, when he has a stable cardiac rhythm, when you don't have an extremely high syntax score, and when his functional class stays in New York Heart 1 or 2, which corresponds to an Intermax 4. In the next slide, I don't want to discuss the next slide, please, because it's a little bit busy and maybe you are not used, but this is the Intermax classification, which is very useful in cardiac surgery and transplantation. But you see that the Intermax 4 is a patient that runs an autonomous life. So this patient normally does not need a mechanical support when is treated on the left main. Next one. But it is important to think that hemodynamic stimulation with drugs is not hemodynamic support. On the contrary, it worsens mortality. The point is that some inotropes may provide you good blood pressure during the procedure, provided that you will do it in a few minutes. If you estimate that you will need more time and your patient will be hypotensive during the procedure, then it's good to consider somehow a form of mechanical support. Next one. So we go with an example. This is an Intermax class 3. There is a moderate LV dysfunction and moderate mitral regurgitation. Let's see this case. Can you hear me well, or do you prefer me
Yes,
to?
yes, we hear you, we see everything.
Okay, so I don't need the headphones. Go to the next, please. You see, this is an old man with 2 unstable angina episodes, normal EKG, and some troponins. Next. We can go quickly. This is, I would say, well preserved, but it's not a severe LV function. The patient has good blood pressure. Next. And although you see that it's a complex left main, blood pressure at the time you put the patient on the table is not normal. So if you start doing this complex procedure with the blood pressure systolic below 100, probably you will be in a hurry and you will do a dirty work. So my advice in this case is to start, the ejection fraction is about 38-40. You don't need very heavy support, but if you put a balloon pump, you will not regret. Next one. Especially if you plan to do complex procedures like in this 111 Medina type bifurcation, with ostial involvement of the two vessels and a discrete amount of calcium. Next one, in which you do rotational atherectomy, which sometimes may be complicated with low flow and more hypotension. Next one. And when you do complex procedures where rotational atherectomy is performed in the two vessels of the bifurcation. Next one. This then, it's a regular culotte. Next one. And the final result. We are not going to talk about the technique. It's just to show you which is the patient in which I implant the balloon pump before doing the procedure. It's moderate LV impairment, it's complex procedure, it's calcified bifurcation, old patient. Next, go to the next. This is a little bit worse. The intermax is 2, the NIA class is 3, 4, the LV dysfunction is severe, it's lower than 30%, the mitral regurgitation is moderate. Let's go to see, it's a young patient, diabetic, very obese, with unstable coronary syndromes, with a very high Euroscore and logistic Euroscore. So, next one, you see the LV function. This is a diagnostic cath. The LV function is about 25%. The end diastolic pressure is high. Next one. This is a culprit lesion, which is the right coronary artery. Next one. And this is the finding of the left main disease. Next one. So, in this case, I mean, there is someone who is not unmute, who is not talking. Please mute the microphone.
Omar, can you mute yourself, please, Omar?
Okay, thank you. So, you see, this is a preventive implantation of an impeller device. Next, please. Why this? Because the culprit lesion is the right, it's totally occluded. But the patient is hypotensive and the intervention on the left main, it's really high risk. So let's go to the next. We do this first. We put the impeller. We treat the culprit lesion. Next one. With a good result. But then we take the advantage of having the patient on support and we treat this thrombotic complex Medina 111 bifurcation of the left main. Next one. Again, I will not get into details on the bifurcation technique. This has been the topic of the past week. Next, what I want to show you is the final result, but in particular, this image in which you see that during the intervention, the patient is supported by a non-pulsatile blood pressure, which is provided by the impeller device. This gives you these 30 minutes you need to complete your procedure with the patient with a saturation 98, with the patient who is awake, mildly sedated, and you can do the job without being in a hurry. Next one. And this is the final result. Next one. I guess that if you treat these patients without support, you will end up in external massage and intubation, and you lose control of your procedure. And we can arrive to some situations when the Intermac classification is 1. This is the patient who is dying because has practically no spontaneous contractility. And this is the case of a very young lady we did years ago. Please show the next one, who was sent to our hospital in advanced cardiogenic shock. And she was put on an emergency waiting list for cardiac transplantation. Next one. But before that, we tried to manage the coronary artery disease. You see this terrible situation of thrombotic subocclusion of the left main and the circ, and a total chronic occlusion of the mid-LAD. Next one. Fortunately, with some collateral circulation from the right, which is also totally occluded. Next one. This patient is maintained alive, although she's intubated, which you see with white lungs and with an ejection fraction at the echo, which is estimated to be 10 to 15%. Next one. You can certainly not do a procedure with your balloon pump or with some inotropes in this case. Being the patient in ECMO, you can treat the patient, you take your time, and then you hope that will be a myocardial recovery. And this is exactly what it happens after complete revascularization. You can see the next one. This patient awoke, and as you can see, 2 weeks later, her ejection fraction was about 38–40%, and she's still alive. So this is the extreme part of the spectrum in which you absolutely need to support your left main patients. Next one. Please, next slide. So this shows you how the intensity of care with hemodynamic support should be higher the lower the intermax and the higher the syntax score. And when your predicted mortality increases according to the clinical evaluation of this patient. Next one. I will leave you these slides. Then, other issues, severe calcification. Next slide, please. It's very important that you consider that rotational atherectomy is not included in the guidelines to treat the left main. Next one is just a consensus of experts. Next one. And this is the case of a quite old patient with very fit, with normal LV function. You can go quickly to the next one, because it's just to show you an example of a patient who is not needing hemodynamic support because his LV function is normal, but you see the massive amount of calcification. Go ahead, one image after the other, and you realize that this is really high risk because of the calcified lesion and the involvement in a Medina 111 lesion. Next. So what we do always is assessment of the depth and extension of the calcium and whether the ostium of the two branches are involved. This gives you the indication to a technique of 2 stents beforehand. Let's go to the next. And again, this is the circ. You can see how much calcium in the bifurcation, almost 270 degrees of deep calcium and black shadows all around the vessel. Next one. And again, go quickly from one to another. This is the rotablation of the LAD, and then next with a bigger bar, step by step. This is very safe to start with a small one and then upgrading to avoid low flow. Next one. And then same thing to the circ. So this prepares the lesion, because what we need is a good stent expansion. Next. As I said before, this will give you good results at the short term, but also at the long term. We go ahead very quickly, one after the other, please. You can move, and it's again about the technique. Go ahead. Culotte technique is my preferred in these lesions, as I have shown you in the previous cases. Go ahead. You see the huge dissection of the proximal LAD, which needs a stent. Go ahead. It's about the technique, culotte, rewiring, and pot. Next. And I want to show you this. Look at the ostium of the LAD. It's not perfectly dilated because it's impossible to get rid of this huge amount of calcium. Go ahead. This is confirmed. This is before and after. But sometimes you have to leave this residual stenosis, because getting rid of this residual stenosis with very high inflation may create coronary rupture, and then you lose all your job. Next one. This is a final assessment that shows that despite the residual stenosis, you see in the bottom part of the screen that the stent, it's a little bit elliptic, but the MLD is acceptable. Next one. Next one. And that's it. We have more than 3 years follow-up of this patient. He's still doing well, almost 90 years old. Go to the next case, please. Another important issue is that you remember this. Start with small bar, upgrade, use IVUS guidance, target the LAD before, and if possible, use one stent. But of course, this is not the case when you have these massive calcifications. We go to another clinical scenario that it's very dangerous in the acute phase of your left main procedure, which is the concomitance of severe aortic stenosis, LV impairment, and left main disease. Let's see this case. 84 years old, symptomatic for aortic stenosis. Show the angiogram, please. And will you find this lesion? Now I will show you something you will not agree, I know, but it's my personal opinion that the way to do is the one I will show you. Go to the next, please. You agree with me that this is a brick of calcium in the left main with a tough stenosis. Next one. So here we have two very high risk situations. Aortic stenosis, calcium in a left main. To the next. What we do in Verona is treating the aortic stenosis first. I know everybody does the contrary. You start treating the left main, but remember, severe stenosis, impaired LV function, calcified left main. If you don't put the patient in assistant, you might be in big troubles because you don't have contractile reserve. When you get rid of the aortic stenosis by putting your valve, go to the next. The patient now, it's a left main stenosis without stenosis. Go to the next, please. Many people is concerned about the possibility of re-engaging the coronaries through the core valve. I tell you, it's just a matter of technique, training, and a little bit of time. But we always manage, I shouldn't say always, but we regularly manage to do this. And again, even to do complex procedures like this. Again, rotablation to prepare the lesion. Next one. Upgrading with a bigger bar, taking your time, and then it's about a regular stenting. Next, in this case, the ostium of the circ is not involved, so this will be a provisional with an onyx stent. Next, and this is the final result. You see the IVUS from the left main to the LAD and to the circ with a very nice result with the IVUS prop crossing easily to the circ. So, again, this is difficult to digest. I know everybody is worried about putting a valve because you have a left main. If the patient has no acute symptoms of ischemia, get rid of the aortic stenosis and then take your time to do your left main with the best technique. Let's see the next case. This is the final result. Okay, next case, please. Next. This is something that we see, we have to remember, I mean, the distribution, the left ventricular function, the age, this is very theoretical. We talked about this in the previous wave last Thursday. We are talking about left main. So all what we do is important in the two vessels. So this does not apply to small branches. Next. The recommendation next of the European Society of Cardiology is to try to put only stent whenever possible. Next. And it has been shown, I am going to talk about the rare eventuality of having trifurcations, which was seen in a very small number of patients randomized in the Excel. And it's important to see that there were no clinical differences in the outcome. It's important to note that the patients with trifurcation compared to bifurcations were very similar. Next. And the clinical outcome was not different in terms of death MI on stroke. The only difference comes here. You see, in the Excel, there is no significant difference because there was no different number of stents in between bifurcations and trifurcations at 3 years. If you go to the next one, this is a Japanese work which says something else. You see that the follow-up of these patients is different. The only real difference is related to TLR. As you can see, it's much higher in the trifurcation group that received more than one stent compared to the group that got one stent. So in trifurcation is clinically safe to be treated, but of course expose the patients to a higher risk of restenosis the more stents you implant. Let's see if we have an example of this. You see, it's a relatively young, 72 years old in Italy. It's a young person with a little bit of low blood pressure with a small lateral myocardial infarction. Go to the next. See, the culprit seems to be this diagonal, but when you do the spider, you find, wow, there is a trifurcation lesion, which was not expected from the RAO. Next, what we did was treating the diagonal just with a balloon and discussing with the surgeons after implanting a balloon pump, because he was about 95, 100 of pressure. But the day after, we decided to do this trifurcation with the provisional stenting of the left main circ. And you will see the final result with the 7 French from femoral this time. Next. And look at the result of implanting only one stent from the left main to the LAD and doing provisional to the ostium of the circ, the intermediate, and the diagonal. Next. Next. And that's it. So, if I think that to complete a little bit what we said in the previous wave last week, 2 stents are always a must when you have massively calcified left mains involving the 2 branches, Medina 111. In all the rest, we always try to do provisional as it's stated by the experts and the guidelines. Show me what's next. Stents are not the same. This will be very short. Excel and Noble. The previous speaker was going into details. Go ahead, so I will not show these. There is a difference at 5 years, which is not as good at 3 years, but still non-significant. And Noble says that surgery is better than PCI. We may leave this for the discussion. The Noble results at 5 years have been published in the Lancet recently. Next. And you see that regardless the complexity of the syntax score, surgery is doing better than PCI. And this is strange because the main difference is not in the highest syntax tertiles, but in the lowest. So there is something, I believe, in the stent platform which is different. This is very important to remember. 10 years follow-up of the syntax study, first generation drug-eluting stent, no difference in between surgery and PCI. Next. And no different regarding the complexity of the left main disease in terms of syntax score, which is this is an old study, but have shown in the compared to study that the stents are not the same. Abdominal biodegradable polymer, Biolumus stent compared to the polymer everolimus eluting stent, durable polymer, the science. Show the results. Permanent polymers definitely perform better in terms of long-term survival and need of revascularization compared to bioabsorbable polymers. So this might be one of the reasons why Noble had a little bit less performance than Excel, but we open this for discussion later. So the stent might make the difference, and so far, until a couple of months, we had only one dedicated stent for left main, which is the Onyx, that you can see has the 4.5 and 5.0 diameters. Next. Now, since a couple of months, we have the Megatron from Synergy Boston, but of course, the experience is very limited. The Resolute Integrity platform is really very deliverable. I am not making propaganda. I know that this is a sponsored session by Medtronic, but I have to admit it's my favorite stent for large left main vessels, and it has a great deliverability and a permanent polymer. Next. Compared to the Resolute Integrity, it has even a thinner stent strut diameter, and it's more radiopaque because it has a nucleus of platin iridium, which is more radiopaque, which is very useful for implantation in ostial lesions. Next. And it's a stent that can be expanded up to 6 millimeters, 4.75 or 6 millimeter, with a very nice opening of the side branch, as I have shown you in the cases with provisional stenting of the circumflex. Next. We can skip this and we go to the next. This is the expansion of the stent. So post-procedural care. Take much care of the renal function, which means try to avoid useless quantities of test with contrast. Use intravascular images that give a lot of information and makes you spare renal function. But apart from contrast media, which is a toxic for the kidneys, the other even worse toxic is hypotension. So don't do your procedure with a patient with 80, 90 millimeters of mercury of blood pressure, because he might be okay, awake and talking, but the kidneys are suffering. And the more the nephrons die, the quicker the patient will die. So take much care of the renal function, because this is one of the main determinants of the long-term survival. Same thing, go to the previous, please. Same thing with the LV function. Before embarking in very complex procedure, make sure that there is myocardial viability. Doing complex procedure in low ejection fraction in patients that don't have a perspective of LV recovery is useless and dangerous. So assess your patient adequately before under the renal and cardiac point of view. Dual antiplatelet therapy, sometimes patients are old and high bleeding risk, so there are stents that have been tested like Onyx, Sierra, Synergy, and Biomatrix that can allow you to interrupt dual antiplatelet therapy in shorter periods than 1 year. Optimal medical therapy, especially in patients with impaired LV function. Physical activity prolongs life, and in some cases, an elective follow-up angiographic could help in very complex anatomies and situations. So if the next is the conclusion, I think I have tell you everything what I wanted to share with you in terms of optimizing your performance in immediate and long-term outcome of complex LMA procedure. Thank you. Tell me you are there and I was not talking alone.
No, yes, we all heard.
Okay.
We enjoyed it. No.
Yeah,
Thank you very much. That was very exciting, and it was a nice tour. Comments? I would like to hear others, my colleagues, before I raise some issues.
Flavio, thank you very much. This is Ömer from Istanbul. It's great lecture, actually. We have seen lots of kind of calcified left main lesion, and all of them treated very well. So what I understand from your cases, when you see a calcification in the left main, you go directly rotablation, right? You don't palpate lesion, or you don't do any NC balloon before. You always do rotablation. Is that right?
When you have a complex lesion, what I have in mind as plan A is to keep always everything under control, which means to keep the patient awake, no need to intubate in a hurry, no need to support because he is hypotensive. And in my experience, the best way to go smoothly in these heavily calcified Medina 111 bifurcations is doing rotablation before. Because if you try with a balloon, the balloon does not cross, or the balloon creates a dissection, you have low flow, you have vessel occlusion. I mean, everything becomes an emergency and you lose control of your physiology. I am happy when I see blood pressure about 100 or above 100. And this is the big advantage of rotablation. It's very predictable. It's very predictable. When you put a balloon, you never know what will happen. You have plaque shift, you have dissection, you have vessel occlusion. This almost never happens if you go slowly with undersized bars and upgrading and doing step-by-step procedure.
I agree with you.
I think, Flavio, that's an excellent point. So, Omar, you have another question, sorry.
No, it's fine. Regarding your TAVI and left main cases, yeah, I like your idea. I would do the same thing. The first, I like to definitely like to treat aortic valve, but maybe I could try first ballooning, in the same session. After the balloon, if I have good results, I may go left main, and after that, I would made to the valve. But obviously, also, yes, we can do valve first, and then we can do. I think we shouldn't touch this left main before we treat aortic stenosis. I fully agree with you. If something happened, we cannot treat patients. Even if, agents and other things will not perform.
So you realize that you two are amongst the minority rather than majority, but I fully take the rationale behind it. And essentially, we obviously don't have any evidence to support either strategy, but what you say makes a lot of sense. But perhaps would the choice of valve make a difference? So obviously you went for a self-expanding valve on this occasion. If you were using a balloon expanding valve and had to pay those 5-6 seconds at 180, would you still be comfortable with such a tight left main disease?
Well, this is one of the driving reasons why I select the self-expandable. If you have an impaired LV function, I would prefer to do it with a core valve. If you have a normal LV function, these 10 seconds of rapid pacing, in our experience, we have both types of valves and experience with the left main performed after TAVI, and makes no problem. What Omer said is very smart. You can do a balloon dilatation, so you improve your outflow, and then you do the PCI, and then you put the valve. It's okay. We started with this more careful approach, but then, we don't want to pre-dilate the valves anymore. It's longer, it's associated with the risk of stroke, so we try to go direct with the valve. So we put the valve, and then we take care of the left main.
So I've experimented with both strategies, Flavio, and the only time I ran into trouble when I tried to do the TAVI first was in a lady with 3-vessel disease and a lot of ischemia and a lot of subendocardial ischemia. And perhaps we did one mistake. We probably should have pre-dilated in this particular scenario. There was a lot of heterogeneous calcification within the valve complex itself. But when we put the valve first, we ended with a lot of paravalvular leak. And this apparently did upset the LV. So the end-diastolic pressure went up really quick with pre-existing subendocardial ischemia. And then we really ran into trouble. We had to a lot of chest compressions and eventually managed to resuscitate her, but it was very messy. So I do take your point, provided that you do not have to survive with a lot of ischemia for a long time when you've put in the valve already.
Definitely.
Now, one other point which you mentioned, which is fantastic, was an excellent talk, more or less of an all-round talk, but the need for mechanical circuitry support is sometimes clear. So you did mention some clear defining parameters, and we obviously don't want to jump into getting the big guns out because they costs in terms of complications, in terms of costs. So we don't really want to overuse them. There is a risk-benefit ratio to keep in mind, but obviously in some cases you can't really do them or get the patient alive out of the cath lab without it. My question is related to the borderline cases. So an EF of 30 to 40, syntax score that is midway between 23 and 33, but perhaps with a single remaining vessel, and someone who is not in heart failure with a systolic blood pressure of 100 to 110. Now, one thing, if you are in a lab where you're accustomed to putting in your MCS platform quite quickly, is having your vascular access ready with your proglides in place and quickly escalating to full mechanical support. But is there any other way in these gray zones, perhaps floating in a Swan-Ganz and monitoring wedge pressure throughout the procedure? Do you ever need a tool to fine-tune your decision?
That of course, it's a very difficult point, and is the reason why we are all struggling to show the good indication and justify the complications of mechanical support. I tell you, my favorite and most simple parameter is blood pressure. You should never start doing, in an elective case, of course, emergency is different. In an elective case, you shouldn't touch a left main, a complex left main with the pressure below 100. So if it's a very simple direct stent, you can give a bolus of dopamine, put the stent, and run away. That's the case. If you think it will need pre-dilatation and post-dilatation, in the case you mentioned, LV function in between 30 and 40 with blood pressure about 100, I would put a balloon pump. But what happens if the things go wrong? When in our lab, we sometimes upgrade. You have already your 8 French introducer. It's not a problem to put the 12 French for the 2.5 impella or the 14 for the CP. And it takes really a few minutes. The problem of these devices is the cost is very expensive. And then, as in everything, there is a learning curve, which is not only the technique to implant is very easy, is the management, is the intra-procedural and peri-procedural hemodynamic management, which has to see with the volume, it has to do with the heart rate, with the position. In this case, you might need, maybe useful to have a Swan Ganz, because if you give too much diuretics to these patients, then you have suctions of the LV. This requires a lot of education. But I agree with you. It's not necessary to be too aggressive from the beginning, but you have to be prepared to upgrade to more intensive support in case of complications.
One last comment, which is fantastic, especially for the audience, in particular, people in training, is what Flavio mentioned about rotational atherectomy. So if you think you will require, so this is not only meant to sort of debulk the calcification or make it easy for stent expansion purposes. It makes life easier in terms of deliverability, in terms of predictability, and having a controlled scene altogether. Rotational atherectomy is not something you want to do with a massive dissection in your proximal LAD extending into the left main. It's not exactly an emergency type or a very friendly emergency type procedure. So doing it in advance, in a controlled fashion, and I think the whole thing is about how can you move in a very structured way throughout the case. So this was again an excellent point, and we've seen disasters when the case could have been done very smoothly with rotational atherectomy, playing around with balloons, then get your cutting balloon, and that doesn't work, get your OPN out, and then this is really when things start to go south.
Yeah. It's very important, Ahmed, because once you have put the stent and it's under deployed, you are risking the long-term outcome of your procedure. Now we have to say, we have an additional player which might be very important. When you ended up with an under-expanded stent, you had a big problem. But now you can treat this with
IVL.
Itotripsy is very effective in expanding an under-expanded stent. So now the problem could be less serious than it was, but of course, if you do your preparation appropriately, you will get with a good expanding stent, which is essential for the left main treatment.
Now, this is my colleague and dear friend, Dr. Ahmed Samir. Ahmed, again, is a person or a colleague I'm happy and pleased to work with on different both coronary and structural interventions. And today he's going to share a case of distal left main disease using the Q-LOT technique. Ahmed.
Thanks, Dr. Ahmed. Thanks to all my professors. It's a pleasure to be among you all. This was a left main bifurcation with a Q-LOT technique, an interactive case. My patient was a 65-year-old gentleman. He was diabetic, hypertensive, obese. He weighs 126 kilograms with a BMI of 38. He had long history of ischemic heart disease. 3 years prior to this presentation, he had PCI to mid-LAD, followed by a PCI to proximal LAD 2 years ago. That was overlapping with the previous one. He had crescendo angina last 4 months. The coronary angiography revealed mid-RCA with subtotal occlusion, severe stenosis in mid to distal left main. He had an ejection fraction of 47%, moderate MR, but the viability of all territories were not questionable. He initially was planned for surgery, but the anesthesia team requested pulmonary functions to evaluate his post-operative course. He had significantly impaired pulmonary function tests with severe restriction. The heart team discussion appreciated that his peri-operative and rehabilitation course would be unfavorable, and the patient was involved in the discussion, and thus a decision for percutaneous revascularization was seen the most appropriate. This was on the day of our intervention. We planned to go first for the right coronary, but we started the procedure with a diagnostic JL 3.5 to see how the left main looked and ensure that the anatomy was the same, unchanged from the coronary angiography that he had earlier. Then we engaged the right coronary with a JR4. The mid-right coronary had its subtotal occlusion, but we realized immediately that the pressure was ventricularizing upon engagement of the JR into the right coronary os. And there was a moderate towards severe occlusion, stenosis at the proximal right, or the paraosteal segment. This is summing up the challenge that we had in this case, apart from being hardly seeing the angiography from his weight, but we have the distal left main, Medina 111, an OM subtotal occlusion, an instantary stenosis spanning the segment of the overlap between the proximal and mid LAD old stents, and another lesion in the diagonal, the very major diagonal that we will see in other views, and the two lesions in the right coronary. We planned for a quick fix for the right coronary first. However, through the transradial route, the JR offered us a little support that necessitated aggressive predilatations and a body wire to implant 348 Zines stent, then post-dilate and Fluorit's inlet with a 3.515 NC. Then we shifted to the left system. Here's the diagonal that we were talking about.
Just show a few more views for the left system and pause for discussion from the group.
Exactly, this is our plan.
Thank you.
This was the spider view. The XP guiding was diving into the left main, and when it comes in proximity with the severe stenosis, usually the pressure dampens. So we had quickly to advance our wires in order that we control the level of diving of the guide. Now we can pause and discuss.
Okay, I think this is a very good issue you showed just now. It's a very interesting case. Obviously, this patient is diabetic and turned down. The optimal management is surgical, but of course, the patient was turned down. So it is up to us, the interventionist, to help the patient. This is a very important point where we stopped just now. I feel we use the XB and the EBUs automatically in too many cases, where I personally prefer the Judkin for this very, very specific point that you showed now. This, along with other points. Obviously, I use the EBU and everything in the XBs, but for selected cases, when I need specific support, CTO, heavily calcified. But for the majority of my left mains, by definition, it's a left main lesion, and we're going to have plaque, and it's a diseased left main by definition. The issue here is not really support, and because once you've crossed with a wire, once you've crossed with a balloon, you will be able, this is very proximal. You don't get more proximal lesion than the left main. So support is not really a big problem here. Whereas those catheters, the EBU and the XB, sometimes they jump in, and I have seen
Dr.
people.
Ayman,
Can you hear me?
now, yes.
Oh, okay.
No, we were hearing you perfectly fine.
Okay.
So your point regarding Judkin's left is well taken with osteal or very proximal left main disease.
Yes, and
So
specifically,
what would be your plan, Dr. Ayman, with that anatomy? I'm just conscious of time. Your plan So how would you proceed with this anatomy?
I only saw two views. I still definitely believe that one single stent is always better than multiple stents, regardless of the technique. If I have better views, I am able to really look at the osteocircumflex and determine that it has a low chance of basically crashing on me and making me have an emergency two-stent, what I don't call provisional, I say one stent or emergency two-stent procedure, which is a different story. It's a much more complex story when it's emergency. If I can exclude this, I definitely go with single stent. If I feel that the osteocircumflex has a lot of disease burden, is high, long lesion, then I will go with the two-stent technique. But my default provisionally will be a single stent left main if I can prove that I feel safe and secure, because I don't like to do emergency acute two-stent procedure. Otherwise, I think a culotte is fine. DK crush is fine. I think either, as long as you know the steps and you do it well.
Okay.
Thank
so
you, Dr.
can we
Ayman,
move?
for
Omar, would you want to tell us how would you move around this case?
Yes, from this view, I think I definitely go with the provisional from, in this case, from left main to circ, and then I do pods. If everything is okay, you know, I would do small dilatation of the stent strut of the elidiosteum, and then I do kissing. To the provisional stent technique, but I fully agree with the Ayman. You know, if the risk of emergent two-stent technique is high, then I would go two-stent technique at the beginning, because this is left main issue. So I cannot lose, if they are big enough, I cannot lose any of the side branches. So you know, I would say that, you know, if I compare my left main bifurcation technique and the LED diagonal or CXOM, my two-stent threshold is lower than other in left main.
Okay, that's very well taken. And the fact that there is going to be quite some discrepancy between the circumflex and the left main diameter doesn't bother you?
Ahmed, I'm not sure if my voice is quite heard.
We hear you well, Dr. Muhammad.
Okay. First, let us agree that, of course, cabbage is first choice for this patient. But as long as we have a problem with his lung, we have to go for left main intervention. Left main in the past, when I was 20 years younger, was a relative contraindication. However, now, after 10 years follow-up of syntax study, we know that there is no mortality difference between left main cabbage and left main intervention. I'd rather to use an intravascular ultrasound to deal with this case. It's important to optimize the diameter of the stent in the left main. Otherwise, we have a problem with sudden death and instant restenosis. So I'm going to ask my colleagues about the probability of using intravascular ultrasound in order to optimize the procedure.
I think it's an excellent point, Dr. Muhammad, and this is exactly along the lines of what Omar said. Now, given probably that we don't have an excellent view where you completely expose the bifurcation, we want to understand the distribution and the burden of plaque in the bifurcation, essentially distal left main and the ostium of the LED. Now, what Omar said makes perfect sense, provided that there is not a significant plaque burden in the ostium of the LED. And indeed, angiographically, it doesn't look like it, but we've all seen scenarios where the picture with intravascular imaging is quite different than angiography. So yes, I would argue that intravascular ultrasound to start with for proper planning, then for optimization, as you quite rightly mentioned, would be the way to go forwards. At least this is how I would do it. I'm interested to know how Flavio would handle that.
Well, I absolutely agree. The intravascular ultrasound will tell you about the diameter of the left main, will help you in selection of the stent, will tell you about the situation of the ostium of the LED, which seems to be not involved, but you never know. And of course, to finalize your procedure will help you to obtain the best stent expansion. So if available, I would do this to plan my strategy at the beginning.
I have a quick comment. This patient had episodes of unstable angina twice, correct? Okay, just to be the devil's advocate. Actually, how do we, I believe you've all already, by the culprit and the right, you did put a stent in the right, correct?
Yeah. Yes, sir.
Wouldn't that have been the culprit? Perhaps it might be a good idea to get an FFR, because here is the issue. If that ostial LED is fine, and I only have a lesion in the osteocirc, which is the least understood lesion of all the coronary vessels, and which is the location where we have the least understanding and basically probably the highest restenosis rate. I'm going to put a stent, supposing the LED is fine, the ostium, we're going to put a stent from the left main to the circumflex. So now I'm converting an osteocircumflex into a left main LED circumflex issue. I would get an FFR or IFR first. Make sure that I have a significant issue in that osteocirc before I convert it from a non-dominant vessel, I think, obstruction into left main affecting the circ and the LED. Once if I have definite evidence of ischemia in the circumflex, then I probably would plan my procedure accordingly. What do the panelists think?
Point of Ayman. Ahmed just moved the angio that I wanted to show you. Yes, that's. I think there is an AP cranial view. Yeah.
Yes.
Now this is a clearer image. Perhaps it wasn't that clear earlier. I think we're dealing with a left main disease plus the ostium of the circumflex. So there's definitely a significant left main stenosis. The only thing that is not entirely apparent is the ostium of the LED. So I think we can, if there is any IVUS data to share, perhaps that can stimulate another round of discussions. But for now, I think we've exhausted discussions. What Omar said seems to be the overwhelming opinion, left main into the complex and consensus, yeah. And if the ostium of the LED suffers, then we can move to salvage stent either in TAP or in Q-lock fashion, unless you have IVUS images to show us. So please go ahead.
I have IVUS to show you, but I have to raise that where when we were performing the procedure, we suspected strongly from the angiography, albeit it was not very clear because of the heavy weight of the patient, that the LED stent is protruding into the left main and is the mechanism of jailing the circumflex ostium. So we are dealing with an instant restenosis at the edge of the stent that is lying already inside the left main, and it is diffuse type of incident restenosis into the LED stent and to the left main shaft. And this was what we have proved after the IVUS. But before we advance to the IVUS, this tight lesion in the shaft of the left main had to be pre-dilated with a 315 NC fire balloon at 24 atmospheres, so we do not have difficulty in advancing the IVUS or we upset the plaque there. I have the IVUS loop, but because it is long, I cut it into frames, but it is ready. If the panelists like to review it, we can do this right now. This was the LED distal to the stented segment, just distal to the stented segment. This were the two layers of metal were there, and there was an under expansion. These stents were 3 and 3/5 stents. However, the stented segments show a diameter of around 2 or 2.5. This was the proximal LED at the emergence of the diagonal, and we see a lot of tissue growth opposite to the diagonal at 11 o'clock, which obviates how the diagonal looks compromised or pinched osteo. And this was the left main. The circumflex, this is at the polygon of convergence, or the figure of 8. The circumflex is coming at between 9 and 12 blocks with a wire inside of the circumflex now getting into the LED or the left main contour. And this was the tightest part of the main shaft of the left main. So we were dealing with a stent that was planned to be put in the proximal or the paraosteal segment of the LED. However, it protruded proximally a bit and jailed the circumflex. Does this change the opinions or the plans?
Flavio?
As I said, I am convinced that the ultrasound gives you a lot of information and you get the best of it. You have well-expanded stents, well opposed, and you have also the confirmation of the plaque, which is, as you can see in the virtual histology, is neointimal thickening. I mean, it's a soft plaque. You don't need for dedicated device for calcium. You will have a good stent expansion without needing very high pressures. So there is a lot of information that you can get from your IVUS study. I think you have done a very good job. I'd like to see exactly the point of action. Sometimes you can use easily your IVUS through the stent struts to go to the skirt and to go to the LED to see the ostium to make sure that you can leave it provisional.
So I think the surprise here, if you look at the bottom left, there are a couple of struts floating in the distal left main at the polygon of confluence, which seems to be, there is some tissue of some ISR, and the stent obviously over there is underexpanded. So my question to you and Omar and Dr. Ayman and Dr. Mohammed, would this push you towards a two-stent strategy at this stage, because it becomes a bit uncontrollable how those struts will behave if you stent left main into circumflex?
Yeah, I think I think it's excellent that you're showing us these IVUS images, which obviously impact the choice of the technique.
So what would you go for?
Well, as I said previously, you can go with either way. I think culotte is fine. Culotte is fine. DK crush is possible, but I think, see, there is the data regarding comparing DK crush and the culotte, and I think it's really, you can't really compare two techniques. It's very difficult. There are different techniques, different angles, a lot. It will always be biased. I know data from the Chinese regarding the DK crush versus the culotte, but I think if you can do the technique well, do it properly is much more important than anything else.
Omar, thank you, Dr. Ali.
Yeah, Ahmed, yeah, I want to ask something. This image at the bottom, this is from circ to left main, right?
LAD to left main.
Sorry?
LAD left main.
LAD to left main. So LAD has a stent already, yes? And
Yes.
I see it's a kind of in here double layer stent. Is that true? How many stents has in LAD?
Now, this is the baseline IVUS study. We have just dilated the left main type lesion to allow the IVUS probe to get in, but the patient has...
He's had 2 PCIs to his LED, so there are 2 layers of metal in the LED.
Already. Yes. Yeah, okay. I think, so what we have here, we have left main stenosis. Ostium looks not bad. So, I treat... Again, what I want to do personally, because LED has already 2 stents, right? I think.
Now you have.
The LED has 2 overlapping stents.
Okay. I would do left main, also left main to circ 1 stent and post dilate nicely, and then I do kissing. And here, what I see after first diagonal, there is a stenosis, and I like to do more dilatation here because, to me, it's stent itself, it's underexpanded. You see, if you go to bottom.
Yes, exactly. Yes. Totally agree.
It's very, very underexpanded. So we have to go here at least 3.5. This is 2, almost 2. So I like to do more aggressive dilatation, and I like to do DEB maybe, drug-eluted balloon here, and I do kissing. So I don't want to put another stent which will be 3rd layer LED. I don't think it's a good idea.
Well taken, Omar. I'll get back. I want to ask Dr. Mohammed, before going to Flavio, do you have any concerns about disfiguring or crushing the very proximal part of the LED stent, which seems to be floating partially into the distal left main, if you go with Omar's strategy?
Actually, first, I would like to congratulate my colleague Ahmed Samir for the choice of the balloon. He actually made good preparation for the black. I'm not sure if the IVUS told me if there is deep calcium or concentric calcium or long calcium, but using 3O balloon, and I see the balloon well expanded, this gives me an assurance that my stent will be expanded as well. Have some stents protruding into the left main, and to manage the circumflex, I have to go through double layers of metal. I prefer to go for 2 stent technique from the start. Actually, I vote for DK crash or kilot. By order, DK crash, then kilot. But I have to be careful about the diameter of the left main. I have to choose the proper diameter of the left main.
Okay. Flavio, so we're down to you.
Well, I will be sincere. I mean, let's see if we have understood what we are talking about. If we go to the right top IVUS image, this is the mid LAD. There is no stent and there is some plaque, okay? I guess that this is not a small MLA area. There is some plaque. I wouldn't touch this. Then you see a stent. I don't agree that this stent is not well opposed. I mean, this stent has 3 by 3 millimeters. And
at
when
this position, it's perfectly expanded and well opposed. You're absolutely right.
The next one, the image which is in the right down corner, is it the proximal? Yeah, where you have the red light now. Is this the proximal LED?
Now, Dr. Flavio, these are running in row. This was the distal to the stented part. This is the distal part of the stented segment in the LAD where it has 1 single layer. This comes from the mid LAD at the overlap segment which shows some degree of instant under expansion, while it is 2 layers of metal. But this should have been larger than this one by physiology.
Well, it's about almost 3 by 2.5 millimeters, and you don't have neointimal hyperplasia. It's a little bit constrained, it's a little bit underexpanded, but the vessel is not much bigger. If you look at the media of the vessel, it's not much bigger than that, and you don't have neointimal hyperplasia. So there is no room for using drug-eluting balloon. And actually, I don't feel that this is the problem of the patient. I would go back.
Totally agree. I totally agree.
I would go back.
I agree.
This is okay. Where you have your red light now, it's okay. There is some calcium. Then if you go still back, the stent is well expanded. There is some tissue, but again, this is, I didn't touch this. If you go still back, you are going back to the left main. Are you?
Yes, sir.
Okay.
So
exactly. This is the figure of 8 of the left.
Can you point us to the slide at the distal left main, or where the bifurcation is?
Yeah, which is the ostial LAD.
This is the point of bifurcation with the major diagonal, and this is where the left main starts. This is the circumflex coming out of the far feet.
And the previous one is still at the bifurcation as well, because I just see this is at 9 o'clock is the wire into the circumflex, or is this a strut floating?
No, this is a floating strut. The wire in the circumflex by this time is still inside the circumflex. We do not see, maybe it's hidden in the shadow of the heavy blooming of the stents. This is wire of the circumflex, which is rather more proximal frame.
So the bottom left is, we're still in the distal left main, circumflex is coming in at 11. And what we're seeing is a floating strut in front of the ostium of the circumflex.
Yes, sir.
Am I reading this correctly, Flavio? Do you have any comments?
It's difficult. I mean, from this fixed image, it's difficult
to.
I'm not so concerned. I mean, I thought it was I thought it was the wire going to the circ, not a floating strut. To make up my final decision on how to treat, I'm not really very concerned of these images. I'd like to see the circ, which angiographically looks much worse. And as Omer said in the very beginning, I would consider going with a stent from the left main to the circ. If you confirm from IBUS that it's very tight, and would do provisional on this proximal LAD. I try to avoid to put a third stent. I'd like to see the IBUS on the circ if possible. And then, as we said, considering that the virtual histology seems to be quite a soft plaque, there is not that much calcium, some small spots.
Yep. So excellent, Ahmed. So can we move, and for the sake of time, we're interested to see how you moved on with the case.
Okay. At this stage, we shifted to a transfemoral route with a 7 French axis because there was great anatomical challenge in advancing any device into the ostium of the circumflex. And we further dilated the left main by a 3.5 NC balloon, and we went to the unspent at an overlap between the LAD, 2 old LAD stents, and there was a significant waste by the 3.5 balloon. Now we dilated the entrance of the circumflex by a 220 PTCA, and it was tough enough that we, at a certain moment, necessitated to anchor into the LAD to be able to advance despite having a 7 French EBU, but we needed too much support than it offered. Then dilated the circumflex of the entrance of the circumflex by a 315. We implanted an ONOX 2.75 by 18 in the tight lesion of the OM to start with and forget about it. And we made use of the same balloon to prepare the carina by kissing balloon with the 3.5 and the 2.75 semi-compliant balloon. We planned and opted for a culotte, and I will ask my professors for 2 comments regarding my choice of culotte to know if it was right or wrong. We already know that we have some layers of metal in the left main, if I implanted a stent into the circumflex protruding to the left main and crush its proximal part, then I overlapped with another layer of metal from the left main to the LAD, I will have 4 layers of crowded metal at the carina, or sorry, at the distal left main. And I believe this left main behaves worse with one single layer of metal, and definitely it will behave worse with 4 layers of metal. The proximal part of the LAD has only 1 layer of metal. So if we perform the Aquilot technique, there will now be 3 layers of metal in the proximal LAD because the overlap segment is far downstream below the large diagonal. And thus we were opting for Aquilot technique. We advanced a 3.518 Zines expedition. We deployed it, then we overinflated its proximal part, and we made use of the same balloon to perform potting. We recrossed the wires, prepared the entrance into the LAD, and then we positioned a 418 Resolute Onyx into the left main LAD. Deployed and botted with the same balloon at 28 first. Then we rewired. We performed bot by a 4.515 with an still flaring further, but at 26 atmospheres. This was comparison between the initial and the last image. Actually, it is not the initial. This was after the dilatation of the left main with the first 3 NC balloon. And this is a cranial view comparing the pre and post.
So you put a stent in the, you did a culotte and then a stent in the circumflex and went through left main to the LED, correct?
I started with stenting the tight lesion in the OM first.
Yeah,
then I performed culotte, starting with 3.5 in left main circumflex, then
correct.
a 4 from the left main into the LED.
And the distal part of the left main LED stent, did that encroach on the other layers of the stent? The distal, the more
it touched. I picked a short stent in 18 millimeters in length, so I did not touch the segment of the overlap. It lies over one single layer in the previously deployed LAD stent that was protruding into the left main.
Looks good.
Thank you. This was our final IVUS image. We ended with a very acceptable MLA in the left main, in the LAD, the polygon or the figure of 8 at the os of the circumflex was showing that it's wide open. And here the circumflex is getting away in the far field, and this was the proximal LAD. The patient was discharged on the following morning safely. And thank you.
Thank you, Ahmed, for stimulating a lot of discussions and debate. Now, I think I will start by Dr. Muhammad and ask you, would you have done things differently? Now, obviously, this is in hindsight.
Actually, it's a very challenging case, Ahmed. Congratulations. The way of thinking and decisions and using an IVUS actually was behind the success of your case. Can I ask you about any follow-up for this case? Because in some segments, there is some metals more and more. Do you have any follow-up for this case, even clinical follow-up?
Actually, this case was 1 month ago, but we plan, inshallah, to have a good follow and a close follow-up to this patient.
Okay. Omar, can I ask you about how do you do a proper pot?
How do I do?
A proper proximal optimization. How do you properly do a pot?
Okay. Of course, after I put a stand, I choose bigger balloon. I don't use the same balloon to do a pot. I never do that, especially in the left main. And I do that as soon as I remove my stand. I don't do anything else. I just put a pot balloon because something could happen, and I may lose wires from either circuit or LED. Then I cannot put them again in the intra stand. So I fear. I have a fear for that. If I do smaller stand in the left main. So according to IWUS, if I do IWUS, according to IWUS, I use, of course, pot balloon. Otherwise, I guess most of the time, at least 4.5, but mostly 5.0 for pot for left main. I do, and after that, I revive and keys.
Thank you. Flavio, how do you avoid some of the common problems such as longitudinal deformation? So how do you avoid deforming the very proximal part of the left main stent during different parts of the procedure?
Oh, well, I think this has to do with the stent platform, mainly. There are some stents that are much easier to deform. They are delicate. We will not make names and brands, but there are some which are more reliable. This is first. Then depends on the plaque. As we said, this was not a calcified plaque. This is why you ended up with a very nicely round-shaped stent. When you have a lot of calcium, this never happens. You have to deal with the trade-off of getting an elliptic stent, and again, depends a little bit on the platform that you have. Sometimes using semi-compliant balloons, you go higher with the pressure. It's enough to oppose the stent. In this case, I would have done with a semi-compliant because you don't have too much calcium. But of course, you understand all these because you have the IWUS. Otherwise, in angiography, you are always happy because you don't see the difference. This is why it's important to have the IWUS on the table when you do the left main. Otherwise, you don't have all these problems. You don't see.
Thank you. I think Dr.
Ahmed, I think that's an excellent question.
Yeah.
Can you hear me?
I can hear you, but I just want to follow up on a comment you made regarding the Judkins left, which I think, besides the jumping in prior to performing your PCI, becomes quite important so as not to deform your stent, especially when you have a jailed wire. Now, it is important to remember when you still have a jailed wire before recrossing, trying to engage forcibly into that left main will inevitably lead to disfigurement of the very proximal part of the left main stent. So that is a point to keep in mind. When you still have a jailed wire, don't try to over-engage. On a Judkin left, perhaps I don't use them much, but it does help on this occasion. So, Dr. Ayman, we can have one last comment from you.
Okay, a quick comment about your question, your excellent question about LSD, longitudinal stent deformity. This is very easy to happen in left main lesions, especially with the pot, because you inflate and then you deflate and you're pulling this big balloon out, and your guiding catheter will deeply engage and can very easily lead to LSD that would not be seen angiographically in a lot of cases. What I do is I deflate the balloon, make sure intensive deflation, then I disengage my guiding. I disengage the guiding while I'm pulling the balloon back. And I think this is very important to avoid LSD. Unless you want to get high.
Thank you very much for the comments. Thank you, Ahmed, for an excellent case. Now we think we can move to Dr. Karim. He's ready with his presentation. And for the audience, please do hit us with any questions. We're happy to address those as they come. I'm sorry, we're lagging with the time. It was a bit of a delay at the beginning. So we've somehow resurrected that presentation, I hope.
I'd like to give a little piece of advice I learned from having so many problems with my presentations and the films wouldn't work. So I learned something a long time ago. When I put a film, I will take a screenshot of one image. So a lot of my presentations, I'll have a video and then just one shot of showing what I wanted to show. That way, if my videos don't work, which frequently happened with me, then at least I have a picture to show the main thing I wanted to show in that. And I think that helps because we always run into these problems so many times in it. So you learn from facing a lot of problems.
I found a sort of a more creative idea that was Blaise Carabello and one of our TEE instructors. They were giving a presentation about mitral valve disease and the value of transesophageal echo, potentially peri-procedure with mitral valve repairs. And the videos, as you would expect, never worked. And then we had this anesthetist who was actually simulating the mitral valve apparatus. And
I like that one better.
It wasn't particularly illustrative. Anyway, Dr. Karim, we've seen you trying to share your screen, but that has disappeared again. So tell me where we are.
Ahmed, are you hearing me?
Yes, we hear you now. Trying to share your screen, but we haven't seen it yet.
Ahmed, if I can ask my colleagues about left main intervention, are they doing it in the same procedure, or when they find left main significant, they just postpone for a heart team discussion or family discussion, ad hoc procedure, or no ad hoc?
Omar? So perhaps, Flavio, what's your sort of personal / institutional policy on that?
We have cardiac surgery on site, which is very good level, and we are in very good terms with our colleagues. So by obvious reasons, we practically never perform an elective left main PCI without a discussion with surgeons and with the relatives and with the patient. Unless it's a very old patient and there is absolutely no reason, but normally we try to share because this is a division of responsibilities, it's a good information for patients, and we do have the surgeons on site, so we don't have a reason why not to do that. But this may be different in other situations.
So patient is not having an acute coronary syndrome, stable patient, significant left main disease, you don't do it in the same sitting. You just postpone the procedure for the discussion.
Yeah. Absolutely.
Omar?
Okay, I think realistically speaking, we have to, each institution, things work different. And actually with each patient, things work different. I never do it immediately. Immediately meaning while I'm on the table without discussing with the patient and the family. I'll stop, I'll explain everything in full detail to the family and to the patient. And the issue is, we can say anything to the patient, basically. We can sway the patient in either way. I like to give them a balanced evaluation of the risks and the benefits and my recommendation. And then I let them decide. If they decide that we will go with intervention, then we'll do it. But a lot of times I will tell them, you have to understand that in this case, surgery is the better option. Better in terms of this and that. And I'm let them make the decision. But I never sway the patient towards PCI. Most of my cases have been talk to the surgeon while the patient's on the table. We'll get the surgeon, we'll have the discussion, and if they decide, then we'll do it. But we'd always have the discussion. And I think the important thing is how you present the discussion. It's very complex. It took us a long time to understand. We still have a lot of issues we don't understand. It's very difficult to imagine that a family or the patient who's panicky are going to grasp everything we say. It's complex. Can you hear me?
Yes, I hear you and I agree. I may add, the discussion should include the degree of success of our team regarding both surgery and intervention. For example, if my center is have very good results regarding CABG, I should tell them, and otherwise also I should tell them about the probability of the two teams.
Okay, I'll just, I think Dr. Flavio needs to leave because he's a bit overdue. And I just, on behalf of all the panelists, I want to thank him dearly for his time, for his contribution. Now, this series wouldn't have been the same without him. And do stay tuned for the last two sessions with calcified and complex lesions, where Flavio is going to join us again. Thank you so much, Flavio, for your time.
All right. Thank you very much. Good luck.
And thank you. Thank you.
Thank you.
Thank you, everybody. Thank you. Enjoyed it.
I think for the purpose of time, and it seems that Dr. Karim is having a lot of technical trouble, we can wrap up with just 3 minutes with a couple of slides just to wrap what has been said. I hope I can share my screen without trouble. And do let me know if you're getting my screen now.
Yeah.
Yes. Normal
Yes.
check.
We can see you.
Brilliant. So this is just for the purpose of emphasizing the need to optimize. And we know from data, although this might particularly apply to the Asian population, so the cutoffs for Caucasian populations and African populations might be slightly different. But this is what you would ideally want to aim for after left main PCI. A minimal luminal area of 5 millimeters in the osteocircumflex, 6 millimeters in the ostial LED, 7 millimeters at the polygon of confluence, and at least 8 millimeters. Now, obviously, we now understand that stent expansion in terms of minimal luminal area is much more important in terms of predicting stent failure, both on the short and long terms, compared to malaposition, which we know by OCT is there, and perhaps we pick it by OCT much more frequently than we do by IVUS with limited clinical value. But we cannot compromise when it comes to minimal luminal area or minimal stent area. And if you want to look further about what you can achieve with intravascular imaging, you also want to make sure that there is no significant malapposition, and significant means something double as much as the strut thickness. And essentially, when it comes to a long segment of malapposition, more than 1 millimeters of struts, you don't want a lot of plaque protruding into the stent itself, and you want to make sure that there is no significant dissection at either ends of the stent. And significant dissection, again, if you look with OCT, we frequently do find dissection, but this is limited, but we're essentially talking about dissections that are either flow limiting or with intravascular ultrasound that extend into beyond the intima into the media, or that that are long, more than 2 millimeters, or that are circumferential, more or less. So you see a flap involving more than 60 to 90 degrees around this. You want to probably fix that or look at that with some concern. Now, we've addressed those points previously, but there's no harm in just going through them very quickly. There are no two bifurcation techniques. There are no two bifurcations that are identical. And there's really no single strategy that can be applied to each and every bifurcation. They do vary in terms of anatomy. They also vary in terms of the clinical scenario. an individual approach is fundamental, and it's important to take multiple clinical and anatomical features into consideration. Now, perhaps we can revisit a DK crush next session with the CTOs, but do remember that provisional stenting, when feasible, is the recommended approach. This is almost always applicable in almost 80%.
Okay, come back. Everybody come back. Hey, haram.
Okay, I mean, we have to give in to your perseverance with that.
Yeah,
so
الرجل
I think
تعب
we
الرجل
will
تعب.
we will just go ahead. Not sure if you hear us, Dr. Karim, and the videos are playing, and this is lovely. So can you hear us now? So we can, yeah, you need to unmute yourself. So we now see the images. If you can hear you as well, that would be perfect. Unmute, please.
Okay, Ahmed.
Yes, that's perfect. So you have 5 minutes. I'm sorry for all the to go through, but thank you very much.
I will try to go as rapid as possible.
Thank you.
To me, this was a male with a previous cabbage presented with acute pulmonary edema after general anesthesia. And this is diagnostic angio, trifurcation, significant disease of the cerebellum and the LED. The LED is calcific and well-functioning to the diagonal. So this is a dilemma. From the chronic surgery aspect of view, this is a time-sensitive surgery because it is a malignant one. It is a high-risk surgery with increased tissue dissection and blood loss. From the cardiac point of view, we are dealing with a high-risk patients regarding the anatomy, the elevated cardiac troponin, the presentation in acute pulmonary edema, undergoing a high-risk PCI, also regarding the anatomy, the calcification, and the need for multi-stents, and the dilemma that he will need that may interfere with the surgery. The plan was, of course, not to do surgery. The plan was to do PCI, then to keep the patient on that between 1 to 3 months, according to the bleeding and the tumor marker, then to go for colectomy. The plan for this lesion was to do a proper lesion preparation, then to decide upon the bifurcation strategy because the anatomy here is obscure, and to use the least number of stents and to achieve the optimum results. And we have intra-aortic diagonal standby. We went.
Dr. Karim, sorry, can I stop you there and ask you to take us to the spider angiogram and only perhaps pause for a minute while we go around the panel and see what they think. Omar, I'll start with you since you're looking so intently. But unmute yourself, please.
Sorry. Can I see the spider wave again, please?
Yes, can we see the angiogram, the actual loop in spider?
And Lima to LED is working, right?
Karim, there is no, the Lima to the LED is not functional, right?
Not functioning. Only the venous graft was diagonal and the right coronary was patent.
Okay. So there is no Lima.
No Lima. The unprotected LED.
Yeah. Omar.
Yeah. I like to see the circ because I like to see if I have to treat the circ. I don't know it. Is there any graft to circ? Oh, yeah.
There was a graft, and now it is occluded.
Okay. So let me see the circ as well, because what I see, I have a long lesion from left main to mid LAD. So I think I have to treat from left main to LAD all the way. Because it's long lesion, and I have seen a circ, and also I have high. Do I have an intermediate artery here or a high OM? I couldn't see well, but I like to wire this artery also. I think it's high IM or intermediate, or is it diagonal?
Actually, this is the circ, and this is ramus giving early bifurcation, and the LED and the diagonal here.
Okay, you know, if avert operation, I do dilate first circ and ramus to see how big they are, or if I have the previous angio to see their size, it's also very helpful to me. If they are big enough, I love to treat them as well. You know, I could stent one of them, and the third one I would do ballooning. So my opinion, I would treat from left main to with LED after nice dilatation. If I have to treat one of the side branches, I would do, in this case, a clot, and then triple kissing if I have to, because I don't see the actually size of the side branches. I don't know, but if they are big enough, I like to take care of them as well, not only left main.
Okay, Dr. Ayman.
Okay.
Very quickly.
I think I heard you say the right coronary was fine.
Yes.
Kareem?
Yes,
the right coronary was fine.
Yes.
It's a dominant right.
It is a large dominant right. Yes.
Correct. Thank you. So I have the myocardium is being supplied by a large dominant right. Now, to me, the main issue would be the LED. I would put a wire in the circuit and the LED and perhaps the ramus, but what I need to do is I would dilate that bifurcation, get some flow into the two vessels, get a feel of what they look like, what's going on. And I would dilate, stent left main to LED, distal LED, and I mean, the more distal lesion, and then go back left main to the LED. That way, I need to get quick blood flow to as much of the myocardium as possible.
Ahmed, can I go?
Kareem, very quickly, this is a trifurcation lesion. Yes, this is the anatomy, but the patient has limited longevity. I'm not going to treat everything. I'm going to try to conserve as much as possible, least number of stents, dilate everything, and concentrate on the left main LED.
Okay. So I will go rapidly.
Sorry, Dr. Kareem, I think just to summarize what everyone is saying, I think everyone is in agreement that the LED is sort of uncompromisable, but I particularly like what Omar said. It's very difficult to understand the size of both the ramus and the OM. And do remember, in bifurcation, sometimes the strategy itself is not clear until you pre-dilate. And
yes, I agree with you, Ahmed. And this was we don't know the anatomy and we don't know the size of the blood vessels, so we opted to dilate, then to decide.
Fire all three vessels and pre-dilate. So let us walk it through, please.
We went with the BMW wire to the LED, and going to the circ was very difficult. We were not able to go to the circ rapidly. So we dilated 1.5 millimeter balloon in the LED left main to modify the plaque in order to get access to the circumference. And this was the result. More compromise to the circ. Now we were able to wire the ramus. Then we went with a larger balloon, 2.5, left main LED. And this is the result. We lost the circumference. But the patient was stable.
Okay, so you lost.
We lost the circumference. Now we had a wire in the race, wire in the LED. The left main was dilated, and then we concentrated upon the ramus. The proper dilation, that is 2 millimeter balloon, and this is the situation now. We have a large ramus was the circumflex, and the left main showed now no significant distal disease. We concentrated upon the LED. We did stenting, 2.75 millimeter. Then post dilation with a larger non-compliant 3 millimeter balloon. And this is the results. The LED is good. We didn't reach the ostia. The ramus is okay, and the circ is lost. But we noticed compromise at the disc proximal segment of the ramus, so we dilated it with a larger balloon, 2.5, towards the LED, toward the left main. This modified the plaque further, and we resumed the circumflex. And now we're able to work again. Now we have a trifurcation with clear anatomy regarding the main, ramus, circ, and the LED. This is the anatomy, and this coil at the origin of the LED. So what would be the strategy? This was our thinking. We will deal with this trifurcation as a bifurcation strategy. Left main, the main vessel, and the circumflex as the side branch. Why the circumflex? Because it showed it is a very delicate vessel that is easily to be compromised. And we adopted the principle of keep it open to the ramus. We used two stent strategy with up front side branch stenting. So that will be operate, because at the time we use the circumflex. This stenting, despite the favorable angle between the circumflex and the left main, I didn't think it may be a good choice because of the geographical miss that may occur, or the protrusion of the circumflex stent on the left main, and it would be a mini crash technique. Pilot will not be appropriate because of the angle and the discrepancy in the size between the left main and the circ. So dick crash is the appropriate technique in our thinking. So we placed 2.75 millimeter stent into the circumflex and 3.5 millimeter non-compliant balloon at the left main LED. We inflated the circumflex stent, then we crashed it with the non-compliant left main balloon at high pressure. And this was the task. We did use the ramus, and we had a crashed stent by the balloon. This is the first crash. Then we had to wire the circumflex using another wire from the approximal cell, and this is important because when distally we may pass into the space between the stent and the lateral vessel, and if we did think this will push the metal away from the orifice of the side branch, causing loss of support. So we wired the vessel proximally, and we did the first kiss, 2.75 millimeter at the circumflex and 3.5 non-compliant balloon at the left main. Then we reduced a 3.5 millimeter from the left main to the LED, doing the second crash. And this was the results. Still, we had the ramus. In the crash, do a first spot here after doing the kissing to keep the stent, the left main and the center circumflex, and this optimize the proximal results, the proximal angiographic results, and direct the opening of the struts towards the side branch, facilitating wiring of the circumflex stent. However, we didn't do this because we did this case 1 year ago, and this first thought was not this well established in our setting. However, now first thought is the standard. We introduced the balloon towards the ramus to open the cell toward it. We did final kissing, and as you can see, the circumflex stent balloon did not go further beyond the proximal few millimeters from the ostium of the cell. I think if we did first thought, we were maybe able to introduce the stent further. This is an advantage of the first thought in DK crash. Finally, we did the final thought with 4 millimeter non-compliant balloon. As you can see, the distal marker of the balloon at the mucarina, and we went into 26 atmosphere. And this is the final result.
Very nice.
And patient had aspirin plus clopidogrel, bisoprolol and atorvastatin, maximum dose, optimum medical therapy. And we followed him for 3 months. Hemoglobin was stable, and he was asymptomatic and fully active. And we stopped the clopidogrel, but continued in aspirin, and the patient had uncomplicated successful sigmoid colectomy. This is related to the technique, the DK crash. And actually, DK crash in the left main is given the level class of 2B recommendation with level of evidence P over the provisional T stenting. And this was based upon the DK crash 5 trial that compared provisional stenting versus DK crash in patients with unprotected left main through bifurcation. And after 1 year, the event rate doubled in the provisional arm versus this limitation where it is only available piece of evidence support this recommendation. Now we have meta-analysis and systematic review with 21 trials with about 6,000 patients that compare different types of techniques. And as you can see, DK crash is the only technique that proved to be superior over the setting. Crash, the conventional classic crash, Kilot, T and TAB did not show this superiority. In other meta-analysis with 26 randomized clinical trial also compared with provisional stenting, DK crash was the only technique that showed superiority. So this meta-analysis may enhance the level of evidence for the recommendation in the guideline. Thank you for your attention.
Thank you so much, Dr. Karim, for an excellent case and for going through all this hassle. I'm conscious we've been keeping everyone behind for longer than intended. So I'll be very quick with 2 questions to our panelists. Dr. Ayman, we obviously try to avoid mentioning stents by name, but I think on this occasion, given the bleeding risk and the need for a short duration for dual antiplatelet therapy, would you consider a particular stent platform in this clinical scenario?
In this specific case?
Yes.
Okay, this specific case is very complex because this is bleeding and ischemic risk. Both are high.
Yes.
This is very different, very high risk. Bleeding risk is high, ischemic risk. Obviously, the shortest duration I would like to give, but at the same time, this is a complex bifurcation with multiple layers. Life is hard. But obviously, something like the Onyx platform, which has been shown in the Onyx 1 trial to have allows you to decrease the duration of your dual antiplatelet therapy, would be a very helpful in this type of patient.
good that we actually have robust evidence now compared to earlier evidence only where trials were against bare metal stent. The Onyx is a good stent. Flavio has shared some of its good values in terms of visibility, but importantly, good expandability profile and the availability of a 4.5 and a 5.0 platform. On this occasion, having such a good platform with data to support very short dual antiplatelet therapy, albeit I give it to you, not particularly in such a complex scenario where you have a stent in the left main in a DK crush format. So it's good, it's reassuring, but this is how complex clinical scenarios can get. Now, my second question is to Omar. Omar, so with DK crush, one thing that comes to mind is DK crush 5, which has been mentioned. There were true bifurcation lesions with at least 50% stenosis in the side branch, the circumflex on this occasion. But how do you go around with your trainees? So with DK crush, for instance, the minimal recommendation was at least 300 PCIs per year for the previous 5 years and at least 20 left main PCIs for the operators. So how do you get your trainees to master such a technique, which obviously has some data to support its superiority? What advice do you give to your younger colleagues?
I think now we have a very nice stent, very literal stent. First of all, in this case, I also would like to use Onyx, not only for bleeding risk. I believe that, and I think most of the operators agree with that. The Onyx is extremely crossable, deliverable stent. I think I have seen Onyx is the most crossable stent, I would say. Sometimes, not some, but always I say that Onyx is not a stent, it's something else to me. If balloon cross, Onyx cross. So I have to say that, Onyx is different than any other stent in my practice. For the trainee DK crush, what I believe, DK crush, these days, we do lots of complex PCI in our labs, in many labs now. 5 to 10 years ago, DK crush or clot stenting is like a kind of, most of the operator, it's a kind of taboo to do clot or other technique. But these days, in Turkey at least, I know many, young cardiologists can do these techniques. So what I suggest them, of course, they should do enough PCI, but also if someone starts to need technique to them, like DK crush or the other techniques, please have proctor at least 10 to 15 Ks beside them. So what we have to do, we should proctor them for the 10 to 15 cases, and I believe after 15 cases, if you help someone for 15 cases, and after that they can do that technique liberally and easily, I would say. So I think
Dr. Mohammed. Sorry, Omar, you were saying something. Sorry.
So the most important point, I think, if they have any difficulty, somebody, could help them. If they cannot recross the stent, somebody has to help them. If they cannot do kissing, somebody has to do it. That's important. If they leave crush without kissing, this is not good. There will be risk of octocclusion. So what I suggest, if someone starts new technique, please have somebody's help.
Do it in a protected environment. Excellent. Dr. Mohammed, I have a very specific question to you.
Sorry,
do you
Ahmed,
think?
I have a cardio steps lecture now.
Go ahead, Omar. Thank you so much. I know we've dragged behind beyond anyone's means. Thank you so much, Omar, and look forward to seeing you in the next wave. Dr. Mohammed, one very specific question to you is, do you think IVUS is mandatory in left main PCI, especially when a two-stent strategy is pre-planned?
Yes, Ahmed, I believe in IVUS, as long as it's available in the cath lab, I feel it's important in the left main. First, it will give me an idea about the lesion I'm dealing with. if it is a calcific lesion, concentric calcium, deep calcium, long calcium. It will give me an idea about the side branch. Is it significant ostial side branch that I will consider two-stent strategy from the beginning? And of course, it will optimize the diameter of the stent, post-stenting, very important in the left main intervention, to optimize the struts of the stent. I feel it's important as in every case of left main.
So you think it's highly recommended, but not critical or a fundamental prerequisite to carry on with the procedure?
Absolutely.
Okay, so I will move with the wrap up, and this will only take 1 minute. Again, I'm very sorry to every one of you, including the audience, for keeping you so late. We did run into a few unanticipated problems, and I hope you're getting my screen. Are you getting it?
Ahmed, sorry, I have to go. I have to give a presentation.
Go ahead.
Thank you very much. I enjoyed it very much. I enjoyed all the presentations. I enjoyed the discussion. سامعني? I don't know.
سامعينك تمام. Sorry again for dragging behind.
La, it's okay. Sorry, I really enjoyed it very much. Best wishes.
Look forward to having you again in the series. Thank you. So we're back to the fact that provisional stenting is the recommended approach in most bifurcations. Perhaps this is more true in non-left main bifurcations. With left main bifurcations, because of the nature of disease and what is at jeopardy, we do expect to see 2 stents in up to 30% of lesions. We've heard repeatedly about the value of proximal optimization. This is not a one-time step. Infrequently, you will do it more than once during the procedure. With QLOT, for instance, you would expect to do potting at least 3 times during the procedure. It is critical that when you go for a 2-stent technique, there is some data to support DK crush, but you've seen that many of us still use QLOT. The important thing is meticulous attention to detail, and you really have to do the technique and master it. And we strongly think that IVUS will help not only with optimization, but will help you through the learning curve to understand how those stents behave in different sorts of anatomies. Kissing balloon is mandatory in any 2-stent technique. It's always best and safe to put a second wire if you are in doubt. If you're dealing with a bifurcation, even when the chances anatomically do not point towards a high risk of side branch occlusion, you will lose nothing by advancing a second wire. So this is recommended, and in trifurcations, the third wire is frequently recommended. Again, intravascular imaging, we cannot stress more on that. You need to know your stent platform. You want to understand how much you can post-dilate that stent, what are the limits in terms of expandability. You want to understand whether this particular stent will foreshorten when you do your proximal optimization. You obviously want to know about the strut design, whether this is an open or closed cell design. Luckily, all stent platforms have improved, but some are indeed better than others, especially when it comes to some characteristics. Now, planning is fundamental. This is your roadmap. So in terms of mechanical circuitry support, we've heard excellent pointers from Flavio today, but the use for rotational, or the potential use for rotational orbital atherectomy, intravascular lithotripsy, concomitant valve disease, and whether this should be addressed during the same procedure or in state procedures. Finally, you want to keep it safe and ideally simple whenever that's possible. And it is fundamental to keep learning. We've heard from experts with hundreds and hundreds of cases under their belt, but they do continue to learn from their own cases and others. And self-audit is fundamental besides your institutional audit. You really want to go dig deep into your results and see what went wrong and how we can treat patients in a better way. Well, thank you so much. Thank you, Dr. Mohammed. I think we can stop at this stage. I want to thank Dr. Mohammed Abdelghani, Dr. Karim Saeed, Dr. Ahmed Samir, and of course Flavio and Omar and Dr. Ayman, who've left earlier. I want to thank the audience who've stayed with us for so late. We apologize about the technical troubles. Hopefully next time will be much better. And do stay tuned for the coming 2 waves. They're going to focus on chronic total occlusions with Omar Göktekin and myself, and again, a highly selected panel. Thank you, everyone, and look forward to seeing you quite soon.